Good morning and welcome to this public briefing of the Standing Committee on Social Development. My name is Jane Wayallen Armstrong. I am the MLA for Mofi, Clichy Region, and chair of this Standing Committee. At this time, I will ask the members in attendance to introduce themselves first, starting from my left.
Julian Morse, MLA for Frame Lake and Yellowknife.
Good morning. I'm Shauna Morgan, MLA for Yellowknife North.
Okay. And members online, please introduce yourself.
Good morning. My name is Danny McNeely and I'm the MLA for the Satu region. Thank you.
Good morning. My name is Cheryl Yakala. I am the member for the Det'anchogh. Thank you.
Mr. Hawkins.
Good morning. I'm Kate Reed. Oh, sorry, Madam Chair. My name is Kate Reed. I am the MLA for Great Slave and here in Yellowknife. Thank you.
Madam Chair, I'll introduce myself. Robert Hawkins, MLA for Yellowknife Centre. Happy to be here. I'm not a member of the Social Development Committee, but this is of interest to me, including our millions of subscribers on the NWT Legislative Assembly social media site. So this should be a very great presentation we're looking forward to. Thank you.
Thank you. Thank you. Today, committee will hear from officials from the Northwest Territories Health and Social Services Authority and the Department of Health and Social Services regarding the Public Administrator Work Plan. At this time, I would like to turn the floor over to our witnesses. Please proceed with your presentation.
Madam Chair, yes, thank you. Good morning. I just want to start by saying I'm joined by Dan Florzone. My name is Alan Duty. I'm the Deputy Minister of Health and Social Services. Joined by Dan Florzone, the Public Administrator for the Northwest Territories Health and Social Services Authority. Kim Riles, the Chief Executive Officer for the Northwest Territories Health and Social Services Authority. Alan Stanzel, Senior Advisor for Governance at Northwest Territories Health and Social Services Authority. And Haley Mado-Young, who's the Senior Advisor to myself. The Public Administrator was appointed in December of 2024 to support the system through a period of transition and to help stabilize operations across the territory. Over the past year, significant work has been undertaken with a focus on 4 key priority areas: improving access to care, fiscal sustainability, governance, and streamlining administrative processes. Before I hand it over to Mr. Florzone to provide his presentation, I do want to comment that the improvements, even though there's still lots of work to be done in the system, the improvements, especially since my short tenure here, it was not without the hard work of the men and women that work in the authority and provide support to the public in those frontline services and those that work through all of the different administrative functions and policy and planning functions. So I just wanted to acknowledge them as we move forward with the presentation. Thank you.
Please proceed, Mr. Florzone.
Great. Thank you, Madam Chair, Deputy. Thank you to the MLAs for this opportunity. I want to begin by just thanking this group and the department and the minister for the great privilege of serving as public administrator. It's not lost on me the privilege of being and returning to the territory to be and witness the improvements and the dedication of the team, the staff, the physicians, in terms of the health and social benefit to the population of their daily work, their daily service. This update reflects the progress to date since my appointment on December 15th of 24. It also captures some of the priorities for 2026. It also integrates this work plan in 2026, integrates the operational plan of the NTHSSA. So rather than have replication or duplication going forward, what we're looking to do is have the priorities of the authority and the priorities of the public administrator fully aligned. These priorities that I'll speak of today arise from this Legislative Assembly, the PA mandate letter issued to me by Minister Semler, dated January 10th of 2025. The authority itself has faced significant challenges, including the effects of climate change, whether it be environmental impacts like fires, floods, and evacuations, the impact of a global pandemic, and the after effects of that pandemic on the system. A national human resource supply issue exacerbated in many rural and remote areas. We've faced persistent financial deficits, and these are only to name a few. Many long-term initiatives were affected during this period, resulting in a backlog of priorities to resolve. Delivery of everyday health and social services remains the #1 priority. This work plan includes my touring of all regions within the authority in 2025. The opportunity for me to go and see, including opportunities to meet and hear directly from members of the regional wellness councils, select community and Indigenous leaders, members of the public and staff, I quickly gained insight and appreciation for the rich cultural history, geography, and access challenges faced by citizens each and every day. Access to care challenges in communities outside of Yellowknife have been and continue to be clearly evident. The strength of the Regional Wellness Council model of governance was also evidenced through the level of local community engagement and input. Communities expressed gratitude for what they had. Frustration was also expressed regarding the slow pace of change, regarding recruitment and retention challenges, issues around medical travel and access to care. This was reflected in the words of a local MLA who was addressing an RWC meeting, describing from the perspective of the residents of the health cabin community, and I quote, "We feel like we're at the end of the road." This was the inspiration for mapping the patient journey through the Det'anchogh demonstration project. The commitment was to examine the care journey by starting with health cabin communities at the start of the road and path to care. The gap between service availability and access in Yellowknife and communities outside of Yellowknife was made apparent. Community engagement was prioritized throughout the year with regular meetings with the NWT Medical Association, NWT Senior Society, and NTHSSA staff. I traveled to all regions to gather insight directly from residents, staff, regional wellness councils, and we'll do this again in 2026. The feedback gathered has been instrumental in shaping the work plan deliverables and measuring impact. In-person and virtual meetings with staff and physicians throughout the NTMA were held throughout the year. Regional visits provided an in-person and virtual opportunity to hear from them directly. Interest-based bargaining was initiated with the NTMA in 2026. The RWC chairs continue to meet quarterly with me, with the Minister of Health and Social Services. So local issues continue to be raised. Priorities of the public administrator continue to be reviewed and prioritized by the regional wellness committees and the Minister of Health. A priority of the NWTMA was to take advantage of an AI tool that held the promise of capturing information and summarizing it in real time, thereby reducing physician workload and releasing time to care. This new technology has been approved and is currently being deployed. A frustration expressed at all levels was the slow pace of improvement work. Staff and community members pointed to the long cycle time to introduce technology, improve booking systems, build and renovate facilities, and to effect improvements to areas such as medical travel. While work was underway to accelerate this work, it became evident that the focus was primarily on long-term initiatives with very little focus on the short-term improvements happening each and every day. A quality improvement initiative under the banner of 52 and 52 was developed to encourage and highlight small improvements, those kinds of improvements that would be low or no cost. These were staff-initiated and patient and client-focused, and they could be the kinds of initiatives and improvements that could be accomplished in a week. 52 changes in 52 weeks has been in place since July of 2025. They highlight how small changes can add up to big improvements. Those weekly improvements are posted to the NTHSSA website. The gap between service availability and access in Yellowknife and communities outside of Yellowknife, again, was made apparent. The Det'anchogh demonstration project included a deep dive into the care journey of residents of health cabin communities. A small team from the authority and from the department visited health cabins and examined care from the patient's perspective. Priority was given to, where possible, providing care at home or as close to home as possible. Based on data and the voice of staff and citizens, plans were developed to be implemented within 30, 60, and 90 days to resolve long-standing issues regarding staffing, training, equipment, technology, and facilities. This reinforced a successful approach to improvement that starts with the patient, examines their journey of care, emphasizes the importance of engagement of staff, establishes clear short-term, mid-term, and long-term targets, and creates the opportunity for cycles of improvement. It demonstrated that better care and improved access can also be more efficient and effective. The review of 600 patient charts from cabin communities in the Det'anchogh region showed that up to 30% of patients could be better served locally if proper supports were in place. These supports include access to technology, including access to the EMR in cabin communities, expansion of telehealth services, introduction of point-of-care testing, along with staff training to support the delivery of more care locally. This demonstration project approach will shift to an accelerated focus on access. It has already in Yellowknife, and was initiated in April of this year. Progress has been made in addressing NTHSSA recurring deficits. Funding gaps continue to be identified and addressed through GNWT funding mechanisms. Work to close gaps related to unfunded medical travel and other program areas will continue in 2026. Stay tuned for our summary financial statements, our financial statements, that are targeted to be released in August of this year. In the fall of 2025, I worked with the authority to review their organizational structure. My overall finding is that while there are opportunities to revisit areas, overall the organizational structure is sound and is reflective of typical organizations of its size and distribution. My direction is that we will work towards incremental improvements over time that align with the priorities of quality and distributed leadership. I'm particularly impressed with the role of chief operating officers and the ability to have the presence of leadership locally throughout the territory. These chief operating officers, working very closely with other superintendents of government, provide the opportunity to continue to influence the social determinants of health, to take on the complex work of improving the health and social outcomes for the population. NTHSA is independent with other authorities, various GNT departments, the federal government, and community-based organizations. There are areas of responsibility overlap in areas such as human resources, information technology, infrastructure, public health, social determinants of health, privacy, justice, cultural training, policy, planning, and budgeting. This will require and requires interagency and intergovernmental engagement to achieve improvements to finalized plans. Significant health and social issues raised by regional wellness councils require an all-of-government approach. On governance, I submitted my report to the minister in December for her review and consideration. I continue to work with her and the department to flesh out and refine the recommendations, and this work will continue in the new fiscal year. I'm very pleased with the work, the progression of that work, and the discussions and considerations that are going on behind the scenes. It's important to get governance right, and it's important to get the organizational structure right. At the same time, the sustainability, quality, safety, and support to this health and social system is critical. In addition, the authorities is supporting the great work of the department on medical travel modernization. We are working towards an accelerated focus on improvements that were initiated in January of this year. This initiative will examine flight bookings, turnaround time for information and flight confirmation flowing to patients, and the approval process for escorts. Nurse case managers have for the first time been onboarded. We're in the process of onboarding them. They provide dedicated clinical coordination of medical travel, which has been long identified as a gap and possible opportunity for improvement. The implementation and evaluation approach to this new service is developed, and recruitment for the new roles has been initiated. It's important to note that this function is one that extends into case management. It's embedded in not only the title, but what we're looking for are opportunities to not only better manage the travel for people with complex and chronic care needs, but also to coordinate that travel. We hear anecdotally stories of visits that take days, arriving in a southern care setting for a 15-minute appointment, when you might have to repeat a trip to that same center in the weeks ahead. Coordination and looking at opportunities to avoid that travel in the first place, or to coordinate that travel with multiple specialists, is a very significant interest. So not only using technology like telehealth and other means to be able to provide care at home or as close to home as possible, avoiding unnecessary travel, which we identified as potentially through the Det'anchogh demonstration project, affecting about 30% of the trips that patients make, but also providing better, more highly coordinated care is a vision for this work. We have, in terms of work plan for 25-26, from January to March, so the first 3 months of this fiscal year, I had the teams focus on several strategic priorities to advance the system improvements and community outcomes. These priorities were fully endorsed by RWC chairs and directed by the minister. They were to accelerate efforts to improve the patient experience with medical travel, so streamlining administrative processes and implementing service standards, preparing work for an in-depth review of access to primary care in Yellowknife, and that work was initiated April 1st and is well underway, and then seeking other ongoing improvements. So maintaining momentum in leadership development, continuing to engage communities on health equity initiatives, supporting staff as the authority transitions to planned organizational change, and reviewing future options for a new governance model. The PA work plan, as I mentioned earlier, will be consolidated with the operational plan of the authority for 26-27. Our improvement initiative of 52 and 52 will pivot in July of this month as the first year concludes. And we're going to bring a focus on those things that prevent practitioners from releasing their time. We want them to release time from administrative processes by streamlining those administrative processes in order to release time to care. More time spent caring, less time spent filling out forms and undertaking administrative processes. This is also a priority of the Medical Association. The NTHSSA dashboard was introduced in the fall of '25, and I'm pleased to say that it'll be further populated and refined to incorporate measures on client satisfaction, quality, and safety. So in summary, the ongoing commitment from me as public administrator, from your department, from your minister, from the CEO and the administrative team is a commitment to health and social services outcomes. Innovative projects and initiatives, it's one thing to start in a place like the Det'anchogh. What we want to do is go everywhere. So spread is going to be a significant focus in this next year in terms of planning out the next couple years on how we go forward. If everything's a priority, nothing's a priority. And what we've found is a significant benefit in starting somewhere, testing, adjusting, and then going to the next place and adjusting there for context. Every community is unique. Every region is unique. What we're bringing to bear is a significant learning environment where we can try and test and engage our teams in idea generation. I'm here for a short time. It's not a long time. My plan, and this has been the plan of the minister all along, is to transition. That transition will be a concentrated effort to look at timing, look at structure, and there's great back and forth that's being considered. No decisions yet in terms of the finalized structure and approach, but those conversations and those considerations are happening. We want to be in a place where our budget is balanced, our quality is high, where we're not only safe physically but culturally. We deliver a service that meets the standards, that we don't have situations where actions are either delayed or insufficient. So we'll be monitoring on a regular basis to be able to pivot, course correct, and deliver the services, health and social services that the population deserves. That's my presentation. I want to thank the committee for your time and patience as I work through that.
Okay, thank you. Committee, any questions? Okay, we'll start with MLA Morse. You have a question?
Thank you, Madam Chair. I imagine I'll have a few. I'm going to start at, I guess, the high level and just kind of following up on things I asked the last time you were here. So the last time you were here, I had asked about what data we were using to measure progress in increasing healthcare access. And I think it's been emphasized a few times that measuring access to healthcare, if we aren't clear about what we mean by that, is going to be a bit nebulous. And so I could be missing something, but what I was able to find on the performance indicator dashboard on the NTHSSA website, it tells a few parts of the story. You know, it measures a couple indicators. I think that the justification given for the indicators we're measuring is that there are things that are measured by hospitals nationally and used to track progress. I could be wrong about that, but what I'm wanting to get to is it doesn't appear to me that we're measuring access to care in a meaningful way. And what I mean by that is defining what we mean by access to care, and secondly, defining what we mean by approving it. So I'm just curious why we're not currently tracking that, and maybe it's because it's in a different place and I'm just accessed the wrong spot on the website. If so, I hope that maybe that data, maybe I just need to click on a different link and I'll find a huge bunch of data that I wanted to see. But I guess, is the data held somewhere else is part of the question, and the main part of the question though is how are we measuring the progress and where can we see that data? Because, when I look through your report, it's mostly, subjective information, I guess, like, we're making progress on this, these things are getting done, but it doesn't tell the story in the sense of like, does a patient have better access to care than they had 2 years ago, in the sense of if they call up a doctor, there's less of a wait time, or, they have access to a doctor or not. It's a little bit hard to tell what the story is right now. So that's my first question.
Mr. Florisel?
Thank you very much, Madam Chair. Thank you for the question. And you're right, we're presenting a work plan. I'm presenting a work plan that really ends at December. We've got now another 6 months of experience and work that's being done. So the dashboard that you see that's being released, that has been released, is expanding. It just hasn't been released yet in terms of the expanded set of indicators. I want to make sure that we don't get crowded with too many. These are really the importance of that focus, is to focus in on the select few that really have meaning for the population. So what I've been, if anything, there's two challenges. On one end of the spectrum, there are too many indicators, a lot of them being tracked nationally. They're great comparators. And for those that want to do a deeper dive, they ought to have that access to be able to do that. The other side is too few. In other words, we're finding that we have to go in and actually audit. In other words, go through charts. Our work on primary care, for instance, meant in Yellowknife meant that we had to go through 100 charts. And those 100 charts, randomly selected, give us insight into what's happening, whether the trip could have been better coordinated, what were the waits and the delays. We're using a tool called mapping. And this is different than just your experience or our collective experience with process mapping. We're trying to look at it from the client-patient point of view and mapping their journey of care. Now, we're stumbling a bit on this. One of the things that MLAs could help us out with a great deal is building and restoring that trust that's necessary. What we want to do is follow patients from the health cabin community to the health center, to the hospital, and then south into care. The reason for going along with that journey is there's data, and then there's a story behind the data, the experience of elders, seniors, patients, clients. That mapping has been enlightening, in part because much of what we measure is our experience of what we provide. So I might say to you, it takes us a day to do this or 15 minutes to do that. But not much of that matters to your constituents when they're looking at it from their perspective, the perspective that we need to look at it from. Now, I know that's a long tale and a long story, but you're going to start to see more by way of the improvements rather than just point improvements like the 52 and 52. We're going to start to talk and describe the whole journey for the patient. So in the Det'anchogh work, we determined that based on that audit of 500 charts, that about 30% of those trips could be avoided. Now, we can't do that overnight. What we need to do is introduce technology, training, supports, provide more care locally. The nurse practitioners that were put into place and have now been underway under a 2-year pilot are proving to show and demonstrate for us some really great initial findings. We're seeing good access numbers. I can give you, we're going to start to release the numbers on how many patients have been seen locally that otherwise would have had to travel down the road to Fort Simpson. We have some data on medical travel. You saw the first iteration of that with the number of trips that people take and make, both inside the territory and out to places like Edmonton. We have now the need to set some targets around that. I'm not sure that I'd set it at the full 30%. I think if even we could say 15% or 10% improvement, and then each and every year look at new methods and new approaches as budgets are made available. So these are really much a feeling of more Gantt-type charts and targets and timeframes as in dates. What you're looking for is output and outcome data, and that's where we see a need. So let me give you a couple of examples just from the CO work that we're doing. This is just a work in progress right now. Each year I set CO objectives. Part of those objectives are now going to have a what by when, a target and a time frame. So this notion that soon is not a time and some is not a number and hope is not a plan, we need to get to some harder targets. It's not easy. No one said it would be, but part of the target I want to set, I'll give you two examples. One is the time it takes for patients to be notified about their approved medical travel. We've heard throughout the territory that patients are experiencing situations where they have less than a week's notice, where literally within days or even hours of their flight, they're getting notified. These are last-minute notifications that don't serve anyone well, particularly the patient who has to scramble and has to make even arrangements for an escort. So that will be clearly one of the metrics, and we're going to set a target around 100% or 0 for a defined population. Now, if we don't get a week's notice, it's hard for us to turn around. Right now, I can tell you that where we don't get a week's notice on medical travel, our turnaround time is 48 hours. You'll know that more clearly when we start posting that to the website. A second example is we've heard from those citizens who have NIHB benefits with ISC, and we know that their benefits, their entitlements, we want to be 100% consistent with the rules of government, rather the federal government and ISC. The reason for some of the lack of clarity in the past has been that we are responsible for a multitude of benefit plans. So being able to make sure that entitlements are being granted, that the turnaround time is there. Right now, the federal government requires pre-approval on some of those requests for escort, for instance, in certain circumstances. Well, we know that the people that we're reaching out to are a Monday to Friday kind of operation, and we're busy trying to work 24/7 with medical travel. So there are some really important improvements that are going on, discussions between the department and the federal government to make those improvements. So I want to take you to a metric that is more relevant, and I think this is really getting at what needs to be gotten at. Access to primary care. We heard from this assembly and from citizens in Yellowknife that they're having difficulty in accessing primary care. So we used a metric around same-day access to primary care. In Q1 and Q2 of this past year, our numbers were sitting around 30-35%. Again, we'll release this. You'll be able to see it. So 30 to 35% of citizens who phone in for an appointment or stand in line for an appointment are getting the appointment the same day. In Q3 and Q4, those numbers have now exceeded 80% of people getting a same-day appointment. Now, just because we've had a gain, that's 2 quarters. I'm interested in seeing a trend, which is probably 3 or 4 quarters. I want to be able to put it up there, publish it, and the spirit of your recommendation, make sure it's up there so we're held to account, so we hold those gains, so we continue to improve, because 80% isn't where we want to be, but I want to be very clear that we need to set more specific targets. Other indicators that show we're not doing as well, we've got speech-language pathology. It's a human resource issue. Our challenge is there. We've heard about the issues around social workers and recruitment and retention. What's interesting about these is we can put the measures up, and we will. We can show where the gaps are, and we communicate the closures or inability to provide those services because of human resource issues. But this is going to take all of government to be able to work through. I continue to be surprised every time I turn around that the territory has trialed or piloted something in this arena, almost guaranteed. Somebody did something here that solved the problem, or at least relieved the problem. And then it was abandoned. And I have no idea what this is all about. It's a bit of a Canadian curse where pilots get started and then they die this terrible death. What we need to figure out is how we start something. Maybe we should stop calling it a pilot, where we start something and we continue it through and spread it everywhere. So much like the Det'anchogh work started in the Det'anchogh, I'd hate for it to stop there. We started with health cabins. I'd hate to stop with health cabins. We need to move to health centers and hospitals and other services. Madam Chair, I think I've gone way too long.
Yes, if you can keep your response short, I would really appreciate that. We have a time limit here, and I have a lot of other members that have questions. So therefore, I do apologize for that, but there's time for, to talk about this too. I'm sure, MLA Morris, do you have a follow-up question?
Yes. Thank you, Madam Chair. Yeah, I'll try to keep this one quick. So, yeah, I appreciate the note on same-day appointments. The only thing I'd note there is that I am curious about booked appointments too, and would note that sometimes people are accessing same-day because they can't get an appointment with a doctor. And so I appreciate that people are getting more same days. I think that's a positive indicator, but I'm curious about a kind of a fuller story. And also, things like number of doctors employed, maybe more importantly, number of patients per care team, ratio of full-time staff to agency nurses, those kinds of things. So like indicators about the various kind of problems and touch points in the system that we've been hearing about that have been problems and that need improvement. So those kinds of things I'd be interested in. Just sticking with the performance indicator dashboard, there aren't any major changes of note that I've been able to find through looking in there, aside from one that really sticks out like a sore thumb, and that is that medical travel is not only significantly increasing in cost year over year, but it is doing so because it's increasing in frequency. And that is a trend, like we were referring to trends versus just a single quarter. Year over year, it's pretty much doubled in 5 years. So the story that tells me is that our ability to deliver services in territory appears to be decreasing. Now, you shared a stat when you were answering my first question that 30% of that medical travel may not even be necessary. So there could be more to the story, but I am curious about that story and what it means. And like it seems to be indicating that residents of this territory are less and less able to find the services, the health services they need in the territory, and they're having to be flown out. So I'm curious about that. It's a big stat, and I realize that it involves everything, but I am curious about that one just because it is the one indicator that appears to be changing significantly.
Okay, Mr. Flores, please.
Dental services, Madam Chair. So there are other indicators, and from time to time, there may be ebbs and flows in medical travel, but dental travel has been the highest burden in terms of those trends. We have some great news on that front.
Mr. Doody, yes.
Yes, I know this has been shared publicly, but, the department just signed a dental service agreement with Health Canada with the goal of replacing equipment throughout the territory so that we can start moving dental services back in the community. And recently signed a contract with Adam Dental to start in communities that already have functioning dental equipment. So these things will be rolled out over the next 3 years, but where you'll see the biggest impacts and gains. But the work has started, and so that's positive. Yeah.
Thank you. Ms. Wells?
Thank you, Madam Chair. I just want to clarify the stat around the 30% of potentially avoidable medical travel. That was based on the sampling of charts that were done just for the Det'anchogh small community cabin work. So it was 30% was primary care type things that should have been able to have been done in the cabin community versus having to have the patient go into Fort Simpson to receive the care. So just want to clarify that statistic isn't able to be extrapolated for all medical travel being potentially avoidable.
Okay. Okay, thank you. Thank you for the clarification. And MLA Morgan, you have a question?
Thank you, Madam Chair. So I definitely appreciate having this check-in and update. The first thing I wanted to touch on is my understanding was that there was a commitment to review the health authority governance and organizational structure to try to find more efficiencies and reduce duplication, for example, between the department and the authority. And my understanding in the initial work plan is that was supposed to be done by last December. I do remember hearing from you early on in your tenure that, you know, coming in, you believed that the structures we have seemed pretty top-heavy in terms of having lots of people in a sort of policy or middle management roles versus how many people we have working on the front lines. And so I was expecting and hoping that there would be recommendations coming forward to help streamline or take away some of that top heaviness, and I haven't seen that yet, and I'm wondering where that's at. But just also noting that certainly one thing I hear from frontline practitioners over and over again is they're feeling that there are many people working, you know, sort of above them in offices, and they don't necessarily understand what they do, and they feel like part of the disconnect with administration and policymakers is that, well, for one thing, there seems to be sort of too many people, often people who were, you know, trained as nurses, doctors, but are now working in management or administration and not working on the front lines. But the suggestion being that maybe there could be less of a disconnect between administration and the front line if people working in administration could at least devote some of their time to still working, you know, practicing, working shoulder to shoulder with people on the front line, that maybe that there would be more sort of natural and organic understanding and communication between people, and that might be one way of helping to fill the many, you know, vacancies and gaps that we have on the front line. So I wonder if you have any response or thoughts on that. Thank you, Madam Chair.
Okay, yes, Mr. Fleursel?
So I'll let Kim speak to more of the practical collective agreement type issues that might arise with management types working the floor. I know that you're talking about a group of a large group of unionized folks that may be able to, you know, roll up their sleeves. I actually support wholeheartedly your notion of going to the floor, understanding problems from the floor, and whether the floor is actually a building or out in the community, out on the streets. We need to get out of our offices more often to be able to go and see and hear and connect. The best ideas that come from those that are in the know, those that do the work each and every day. And that's not just a statement, that's a fact. And that's rung true throughout my experience. We do, I have looked at senior management, and I've looked at governance. I did complete a report with recommendations, but of course, just because I recommend something doesn't mean that it's going to be accepted. And there is a discussion and discourse that needs to take place. So I think, and I believe that it's being thoughtfully considered and actually improved upon in terms of the ideas that I've put forward. We've identified some gaps and overlaps with the department, with other departments as well of government. I've made some comments in my recommendations around the authority having, should it persist, having the authority to make some decisions and to be able to reallocate resources and make some changes and shift positions from out of scope, or sorry, management into direct delivery and from community to community. To a large extent, that authority rests with this House. The positions and the position detail is really, and it's surprising, but it's really not the purview of the authority. We can make recommendations, but we don't make those ultimate decisions. So I'm really trying to put forward a case where we're not only accountable, but we have the authority to make decisions around moving resources to be able to respond to where the needs are, and not take a year or 6 months to do it, but to act in a very nimble way. The other thing in terms of the administrative burden is that we've got a lot of people that are simply dedicated to responding to the questions that are raised at committee level, at department level, through the minister's office, from citizens. And I'm not saying either way, but the BFs and the workload, it's unusual to have a direct delivery agency play that part in responding to the House. We have operational detail that's important, but we're trying to run a system, and we're trying to create the kind of reporting, and there's a lot of administration that's involved. So reducing the administrative workload is one way of reducing the administration on this system. It's really hard when we say reduce, and I certainly have put forward recommendations around reductions. It's really hard to do that when the expectations continue to rise for what we need to produce. So more to come, more to be said on the budget and where we're at. We're going to balance the budget. So we have a target to balance the budget. We're going to give priority to frontline staff. And at the senior levels of the authority, I don't see anything that really is the problem. It's an interesting narrative, but it's not the problem. I'm still interested in looking at the middle.
Thank you. Amelie Morgan, do you have a follow-up question?
Thank you, Madam Chair. And as you say, I'm also interested in the middle. And so was just hoping that we would have more insight by now into that. But on the topic of balancing the budget, so you have said that that is coming, and I know that, we were initially told that last year's budget will be balanced, and then this year, and now we're saying, okay, next year. But so far what we've seen, what the public has seen is an increase in fees. In a few cases, we've just heard about, new long-term or new fees for people staying in hospital while they're waiting for long-term care. There's a switch over to, anyone who is not insured under other means or under NHB that needs medical travel now having to be under extended health benefits, and there's worry that if people don't sort of register themselves properly, they might end up having to bear the cost of that themselves. So I think what the public is worried about is that the balancing the budget will be on the backs of people paying more fees themselves. And that's not what any of us want to see, I don't think. And it also doesn't seem believable, I don't think, that the problem this whole time of why the health authority's budget wasn't balanced was because the citizens weren't, paying enough fees. But I wonder if you can comment on whether that is a primary part of the strategy to balance the budget, is to increase fees to patients and people in the public. Thank you, Madam Chair.
Mr. Flores, Mr. Duty?
Thanks, Madam Chair. I'll start just because of a couple of the policy changes that have been implemented, and ultimately policy changes are those of political decision makers. Like we do make recommendations, but the rationale on the fees in acute care are tied to people that are actually their next step is long-term care, and they're using acute care bed as a long-term care bed. So that was the rationale for that piece. And the extended moving things under the extended health benefits is actually supposed to streamline and improve access for citizens. So that may actually end up costing more money, and because maybe more people will access over time. But those extended health benefits, moving medical travel, for example, and things like that under extended health benefits are all to reduce administration, but also to improve access to benefits. I can't speak, I'll pass it back to the PA and the CEO to talk specifically about their budget.
Mr. Flores? Yes,
Sorry,
please
Madam
proceed.
Chair. Thank you. I have not completed my work on looking at revenue and revenue ideas. I have to say, when I look at revenue, the key bucket is ISC and making sure the federal government is paying their share, and we're really confident that we're making some good progress there. These odds and sods and fees and, charging from meals to parking to, I suppose in the South, private accommodation, like these are not big ticket items and they place a burden on patients. I acknowledge what you're saying. And I think I need to be really cautious. Your caution is well accepted, that we're going to somehow balance a budget on the backs of those we serve. It's not going to happen. It wouldn't even be significant enough. So there is some good work underway with the sustainability unit in looking at what's core and what's not. There's some really good work underway right now within the territory. One of our problems with the authority, this idea of a balanced budget, is I'm really focused on balancing revenues and expenses at year end. Balancing a budget is presenting something that has yet to be concluded. It's in advance of the year. I want to balance our operations. In other words, if I get an approved budget that says the budget's going to be a $20 million deficit, I want to work towards, during that year, getting to zero, or as close to zero as we can get. Now, we do have a statement around balancing a budget, so that becomes a little more of how do we figure out a way in advance of the year, before we've done all this good work, of bending the cost curve or identifying where we can best bend the cost curve. Stay tuned. I mean, August, we'll know what last year's actuals were. And I'm much more confident in where things are going with our actuals. But you'll be the judge. You'll be the judge.
Madam Chair, if I may.
Yes, please, go ahead, Mr. Dewey.
Yeah, so I'd also like just to build on something that Mr. Florzon has said as well, but also highlight some of the work that's been ongoing. So the focused work on primary care, on med travel, support to small communities. Some of these things are going to actually result in new expenditures that we probably never had before, but ultimately will end up in some savings in the system, like reducing medical travel for those that don't have the travel. Medical travel is very expensive. You think of someone that flies out of somewhere like Palatine, for example, is an $8,000 round trip just to get them out of their community. But if we're delivering services closer to home and we're investing in the right processes and staffing to allow that service to be delivered at home, that cost will be minimal. It may show growth in some areas, but overall to the system, it will eventually show cost. The other thing that doesn't happen in our budgeting process is that there's no automatic CPI added to budgets and things like that. So you got to realize, like, sometimes you're building a deficit, but we're not necessarily budgeting inflation either, right? And inflation has been something that's been significant especially since COVID. So like we also need to keep that in mind when we think about, like, you're building a deficit. Even if you started with a balanced budget in 2000, if that's still your budget and you're providing the same services, you're automatically in a deficit just based on inflationary costs and things of that nature. So sometimes that gets lost in the conversation as well when we're talking about balancing budgets.
Okay, thank you. Okay, so we're okay? Okay, next I'll go to Mr. McNeely, MLA McNeely. You have a question?
Thank you, Madam Chair. And thanks to the department and the PA for the update. What I'm thinking is, I heard your self-evaluation. You've got mapping, and you want to go and track the patient's journey, and you're going to release some numbers on actuals, and let's wait and see here in August. I'm thinking about medical travel. Medical travel is a huge cost, as we all realize. And I hear you. I hear you definitely, but on a holistic report or approach, taking your report out to the communities, out to the regions, to share with the leadership and have a session, let's say Inuvik or Simpson or Betchico or Norman Wells, you bring in the you bring in the leadership and make a joint presentation as you are doing now, and sharing what you are doing to minimize cost and increase sales or revenues, so that people out there are well aware of your, call it, deficiencies or gaps on delivering healthcare. You want to deliver healthcare, but you really can't do that because you don't have enough staff. Recently, I got a memo here that the reduction in healthcare services was reduced in Fort Good Hope, only because there's a shortage of staff. So if I take your report and hold a session in Norman Wells and make the community parents and leaders and board members and RWCs well aware of your challenges, and let them know this is how you can assist me and help me by recruiting and emphasizing education for trades. We need more nurses. Let's take that message and share it with the leaders so that they know that it's really a holistic approach to help you improve delivery of healthcare. And so my question is, realizing that problem, are you planning to have regional healthcare sessions in these regions of the Northwest Territories? Thank you.
Thank you, MLA McNeely. Mr. Florizel?
Yeah, thank you for that question. I do plan, and I'm hoping, I've encouraged the RWC chairs in this next round of invites to not only attend their meetings, but attend their public meetings. In the last round, the minister and I and the deputy attended a number of these sessions as well. Our CO was there. We'd be more than happy to do it. So for any of the MLAs that have an interest working through the minister's office, I would be pleased to organize broader sessions to talk about what's there. Often with these presentations, it's almost like you make a presentation and you don't really focus in on all the problems that we're actually trying to work on. Often you get the fluff around, here's the good work that we've done, this is what we did last December. What it comes down to is that this system is not in crisis. And when I first arrived here, that word was being bantered around left, right, and center. This system is very well managed. And while there are problems, we have an opportunity here, and I think a winning formula by following the patient-client journey to resolve those problems. So if given the chance, I would take this team over any team I've ever worked with. I would take this leadership over any leadership I've ever worked with. And if you want us to resolve problems, we'd be happy to. We'll go into it with the proper measures, metrics, targets, timeframes, and do it. But if you throw everything at us all at once, we're just overwhelmed. We don't have the capacity. So there are some real concrete HHR issues, health, human resource issues. If we could work with committee and with government, this starts in grade 3. This starts in grade 9. This starts in following Indigenous children through their journey, because representative workforce is really the key to our problems. I just can't control it from where we sit. I can't. I can talk about it, but I can't influence the improvements that are necessary. And my point earlier around we've piloted at just about everything in the territory, I'm saying we solved this or improved it in a big way in our past, but for whatever reason we dropped it. So Fort Smith, where we hear about social workers and how they were being trained. This is a huge opportunity for an all-of-government approach that says if you want a representative workforce in all fields, not just health, but the trades and all fields, we can contribute to that. We just can't lead it. The people strategy, great that I have a document and it's been submitted. But that's not an NTHSSA strategy. We can contribute to that strategy and we have a role to play. That's a government strategy. This is every authority, every department.
Thank you. Thank you, Mr. Florzone. We are aware education needs to be improved, especially in small communities. I'm glad you said that. Yes, Mr. McNeely, MLA McNeely, do you have a follow-up question?
Yes, I do, Madam Chair. Thank you very much, and thanks to the PA for that response. My next question is still medical care or medical travel. Recently, during the spring months and fall months, Premier and Cabinet have these bilateral meetings with the claimant corporations, and we recently had one. We had one there between SSI and the Premier and Cabinet, and medical travel was on there. What role is your job doing to rectify the medical travel for the SA2? You know, I still constantly get calls and texts for assistance. My medical travel is going to leave within the hour and I'm not ready. And I just got notification here, and my escort feels the same way. So that short notices for approvals, it still exists, and it has been existing for a number of years. And we also suggested bringing NHIB office to the Yellowknife community, bringing the decision makers closer to the clients. As you know, the department, there's a 2-hour difference to Ottawa approvals. So that contributes to delays. Has there been discussions on bringing solution to the bilateral medical travel, such as bringing NIHB office closer to Yellowknife? Thank you.
Okay, thank you, Mr. Duty, please go ahead.
Yeah, thank you very much for the question. So there are active conversations ongoing between the department and Indigenous Services Canada on exactly those types of things that we rely on the federal government to approve. They need to make some changes to policy, but we are trying to have delegated authority so that we can make these decisions locally, and so that work is ongoing and it's progressing. I don't want to give a timeline, like, to be quite frank. I would have told you 3 months ago that we had this in hand and it was on its way to being resolved, but we don't control the Indigenous Services Canada, unfortunately. So but this is a very active conversation. So there's, I'm under the impression, I just had an update on this actually as recently as yesterday, that the conversations are going well. So we're hoping that by the end of the summer, we'll have some resolution to those things that we rely on Indigenous Services Canada for, that we can actually make these decisions in territory around things related to their policy.
Okay, thank you. Next, we'll go to MLA Akalaya.
Good morning, and thank you for your presentation. I appreciate that. I'm looking at the NTHSSA and DHSS, like, to find ways to increase revenues. And one of your announcements was to increase or to charge people for long-term care beds. What is the rationale for proposing or implementing the fee scheme for long-term care beds? You're effectively putting pressure on families and communities to increase revenues for the government. Thank you.
Okay. Thank you. Mr. Duda, yes.
Yeah, thank you very much for the question. Hopefully I'm not going to answer your question. So the recent change in policy related to those that are in ALC beds that are destined for long-term care, like they are not leaving ALC and they're holding ALC beds for long-term care. So that was a policy decision that was recently made and announced. And that rationale is because the rationale behind that is because if there was a long-term care bed available, they would be in that long-term care bed. Because ALC beds are also are more costly to operate when you think about the services that are provided in an acute care setting. I think there's I'm going to speak to this, but I may have to correct myself, but I believe there's an annual increase on long-term care fees that happen every year at a certain period of time, but I'll have to confirm that. I'm not 100% sure if that's the case.
CPI.
Oh, it's a CPI increase. Yeah, sorry. Thank you.
Good. Thank you. MLA Akalaya, do you have a follow-up question?
Prior to doing this, you talk about, working with the regions, working with the communities, and working with the Indigenous governments. Were they consulted regarding this this increase? And if they were, what was the response you got back from them? Thank you.
Mr. Duty? Okay, yes, go ahead.
Yeah, thank you very much for the question. I'll actually have to come back to you. I don't have the exact answer. Like normal protocol is that there is consultation, but I don't recall offhand if the staff had consultation through the Health and Social Services Working Group on this change. So I'll have to get back to you on that. Thank you.
Thank you. Next, we'll go to MLA Hawkins. MLA Hawkins, do you have a question?
I do, Madam Chair. Thanks for the opportunity to do this. Again, I'm not a member of the standing committee, but in some ways we all are. It was good excitement to be here. Madam Chair, my questions are really to be direct. And so I guess the Health Authority is plagued with their deficits and their challenges, but there's been some major delays in the initiatives of slashing corporate overhead and middle management red tape by a year, if I understand this correctly. So understanding that there's a protection of this middle management and red tape, basically desk jobs versus finding meaningful ways to hire or implement new frontline services that are underfunded, because the system is now making the everyday citizen a co-payer. How do we justify this paralysis? Thank you.
Mr. Floresville?
I think it's probably important to note that nothing about this has been slashing. This has been an approach that is, I believe, to be thoughtful, reflective, looking at quality and safety, improving care and reducing costs at the same time. We've done some initiatives that have looked at the pebbles in staff members' shoes, the things that get in the way from them delivering direct care. And part of that is to release their time so that they can care. In terms of the efficiencies and approaches that we've taken, there certainly are areas where we can improve care and reduce cost. Medical travel and appropriateness of care at home or as close to home as possible is one example of that. So we're going to start to see some improvements there. Right funding is the federal government coming through with recognition of appropriate funding is a key element and has been, there's been great progress there. The reduction in dental, while we don't deliver dental care, the authority doesn't deliver it. Our medical travel staff do organize the travel around that, and it's placed a burden on the infrastructure, the staff, the boarding homes, and what we're looking for is a better way. So the improvement there is reduced costs, likely more to the federal government than anyone, but also a better situation because you can get your dental care at high quality closer to home. So we're really trying to emphasize here that there are some efficiencies to be had. there is bureaucratic paperwork and forms and steps. The idea isn't to slash those, because if we slash them, you wouldn't be getting much for anything for information. There's some value at some point, at some time. And those things that we can eliminate, we certainly will, but we'll do that thoughtfully with the staff. So rather than set the whole thing ablaze, slash and burn, we'll do some controlled burns. We're going to look at areas where we can seek those improvements. Not everything can be improved at once, so we're going to start small. And the elusive part I mentioned earlier is the spread. We're going to have to get really good at spreading. So things that work, tried somewhere, let's try them somewhere else and eventually get everywhere.
Thank you. MLA Hawkins, do you have a follow-up question?
Sure do, Madam Chair, sure do. Well, the next one's going to sound critical, but I mean, at the public service payment of a public administrator, I mean, I'm sure they can shoulder a little bit. To be frank, in talking to some MLAs, including extensively the public healthcare workers, whether they're nurses or administration, I mean, the constant perspective is all we hear is platitudes, and yet the engagement of seeing stuff. So platitudes being, we're working really hard, we're making great progress, we're doing good things. And at the end of the day, it feels like we're not actually seeing any action that rolls out to anything meaningful. So when we hear, and I'll allow the PA to correct if I misquote him, I'm not trying to quote him word for word, but intently the intent it is. And I believe the PA promised that we'd get to some degree, that is, I'll say it this way, to some degree, I believe the PA promised that the Northwest Territories would get a clear enforceable standards for medical travel administration by early 2026. To me, that's a very clear outcome from we're going to do hard work to we're actually showing you we're actually doing something. And I think the intent was to fix the broken system, but we're now past the deadline. And so without clear standards, but very clear platitudes, the public doesn't feel like either the deadlines matter or we're actually doing anything other than making great statements. And so at the end of the day, what can you say that we will see get done, feel get done, and certainly know is being translated into results for Northerners? Thank you.
Thank you. Mr. Floresville?
Okay, just in terms of the work to date, I'm just going to have Kim, our CEO, comment on a bit of that, and then I'll follow through and try and succinctly answer that question. Kim?
Yeah, go ahead.
Oh, this one. Okay. Thank you, Madam Chair. We talked about data earlier and the need to present like concrete data and information. And the public administrator mentioned the dashboard that we launched in November of 2025 as our starting point for that actual public reporting and monitoring. What I will say is this is a process that for this organization is in its infancy. We have myriads of data, like we have data all over the place, but what we didn't have was a platform to actually report that and be able to have you be able to click on it and get more information and that kind of thing. So building the actual capacity to have that presented in a public format that was usable, we've had to actually start kind of in our infancy with that. And then the other pieces that we've had to do are to take all the various data pots that we have and actually have someone do a review of the data integrity to be able to actually put them on that website in a way that they're valid, that we know that we're measuring apples that compare to national apples, for example, and that we actually have clean quality data to be able to report. So as the public administrator has stated both today and other times that he's met with you, being able to have actual results to show is really important to him, and it's been part of his direction. It's why the dashboard was launched and why it's a priority for this fiscal year for us to continue to mature and enhance our public reporting of data. It's just not fast. And so I have excellent information around access to care, for example. Mr. Florzone shared the information around same-day access, like how we've gone from, you know, a very low percentage of access, like, so for the number of people who call for a same-day appointment here in Yellowknife, for the percentage of those that we've been able to actually meet their need, over the quarter, where it was like sitting around 60%, at Q1 of last year, to being able to get that up over 80% by the end of the fiscal year. We've seen increasing trends in access to all of the types of appointments here in Yellowknife, as they've done some really great work in those teams with their LPNs, with their community health nurses, with their NPs, with the physicians, to be able to, you know, be as efficient with their time as possible and actually try to get more appointments available for the public. We have that information. I want to be able to report that publicly, and we're working to be able to do so, to be able to demonstrate that progress that I hear from MLAs that you're seeking, that visibility. We've talked about the introduction of the nurse practitioner pilot as part of that demonstration project out in the Det'anchogh. That went live in late December. I've just received the first quarter of data. We've had hundreds of encounters for those 4 small communities. We have less than 400 people that live in the 4 small communities that are being served out there. Greater than half of them, almost 3/4 of them, have had at least one encounter with a nurse practitioner. So we are collecting data. We are just in our infancy of being able to get that out to you in a meaningful way that is digestible. So I would really ask you to kind of stay with us as we continue to work on that. We have a lot of good news stories. As the public administrator said, we also have a lot of problems and challenges that we continue to work on, and we are working on them. But we have also done some really great things. We're just in our infancy in being able to present that information to you in a meaningful and accessible way, but stay with us because it is a priority.
Okay, thank you. Now we'll go to MLA Reid. MLA Reid, do you have a question?
Yes, I do. Thank you, Madam Chair. I really appreciate the opportunity. On slide 8 of your presentation, you mention organizational changes. Could you explain what planned organizational changes to the authority are in the works as referenced? Thank you, Madam Chair.
Okay, thank you. Mr. Florzone? Oh, Ms. Wells?
Thank you. As after the information and review that Mr. Florzone carried out back in the fall, the key principle and direction that he gave us was to continue to work to ensure that reporting relationships within the organization were as decentralized as possible, that we were making sure that where staff were reporting made the most sense operationally, and were as kind of distributed as possible within the region. So for example, in this fiscal year, there have been changes to the reporting relationship for our dietitian service. That has been decentralized, and now those teams are working within the regional teams as opposed to having a territorial service. Corrections Health Services has also been redistributed to report within the regions, as well as the Adult Services Program. We're continuing to look at other areas. As folks will know, we transferred responsibility for shelter services here in Yellowknife over to housing as of April 1st. We have some other work underway with just internal restructuring to make sure that, like I said, programs and services are most aligned with where it makes sense within regions, and so that they can be most effective and efficient and work in their teams.
Okay, thank you. Ms. MLA Reid, do you have a follow-up question?
Yes, thank you, Madam Chair, and just to Ms. Ryle's answer, I hope that those updates can be shared with committee as they roll out. My next question is in the report, it's noted that the work to the middle management series, which was identified as part of the authority's commitment to reduce corporate expenditures and red tape, it was delayed from November of 2025 to fall of 2026 due to internal capacity challenges. Can the presenters please elaborate on internal capacity challenges that they're experiencing, and whether or not these capacity challenges are affecting actions throughout the work plan and how they are affecting the work plan. Thank you.
Thank you. Okay. Mr. Florisel?
What I'm going to have is Kim give you a general overview. I want to, and I want to make sure it's not my rant, but it seems that we encounter curveballs continuously in terms of new and emerging priorities. Some of these are outside of our control. They're environmental. Others are well within someone's control, just not ours. But it's fascinating to me how we're managing to make progress when there's always some emerging priority that attempts to disrupt the progress we're making.
Yeah, Ms. Wells?
Thank you. So yeah, so the specific question around the middle management series, that is on schedule to launch. They're actually reviewing modules now. They've been using them with test groups to see how they go, and so that is on track to hit the delayed target. In terms of last year's capacity, we had undertaken as part of our expenditure reduction plan a significant number of managed vacancies internally for positions that were administrative, non-frontline in nature, and the division responsible for the development of that program was in particular one where there were quite a few managed vacancies to help us hit our expenditure reduction target. So some work had to be delayed as a consequence of that.
Okay, thank you. I do have a question as well. You know, when we were discussing healthcare services in NWT, Premier used Ford Focus and Cadillac describing our healthcare services in the NWT. And in small communities, this is where I was saying that, you know, in small communities describing the healthcare system to these two, we're not near that. I think if we're, you know, using this analogy, we have Old Bitsy. So in small communities, and I know that you talked about the medical travel modernizations, which is greatly needed because, you know, especially for elders, and, you know, sometimes the notice are given the day before. Even living in Det'anchogh, and I had some people, you know, have issues with that. They have concerns because there's childcare, there's all kinds of things that they have to take into consideration before, you know, going for their medical travel, especially when they're leaving that territory. And with this is where, especially for elders, you know, elders, they need interpreters. And that was not clearly outlined because most of our elders, even though they have a medical trial, on the doctor's note, it says interpreter required, and yet some of them are still not being approved. So when that happens, it's another agency or another organization that looks after the medical travel for that patient, and it happened a lot. But now that, you know, I was talking to Minister Assistant, said that it is an automatic approval when an elder requiring an interpreter. Even in the hospital here, like, you know, they go on the ambulance, they travel with their family, but so it should have been. But now that it's too much stress for the person traveling as an escort, and not only that, even with air ambulance or medevacs, elder getting on the or being sent to Yellowknife for on the medevac plane. Sometimes we don't have plane, you know, going to the small communities for 2 days. So an elder, you know, if it's after midnight, there's no medical services or medical interpreters available. So somebody from the outlying community, especially in Det'anchogh, somebody has to come here, travel here. So You know, I mean, that's, you know, I'm glad that you guys, you know, there is some improvement. So, so can you tell us more on that with the interpreter translations? Because that's usually an issue. So, because people are listening, and I'm hearing one from, you know, it should be an automatic. So from your view, is that an automatic medical travel escort for interpreter's translator? Thank you. So who would?
So just a couple of words on this. I don't think it's Old Betsy. I don't think it's a Cadillac either. I think it's probably a really good Toyota with work to be done. And what I see and what I witness, I wish we had in the South. I think we have a model to share actually with the globe, the world, and it may have been better at some distant past. It may have eroded given all that's been thrown at the system, including COVID and a pandemic. But there's a really strong foundation of team-based primary care. The complexity of medical travel is astounding as you start to break through, and this is where we're diving in deep. We want policy clarity. We want rules clarity. We want the ability to communicate those rules, not only to the practitioner that's making the note and either responding or raising expectations, but also to the patients so that they know in advance or can tell what they're entitled to. We want to make sure we're matching that standard. So these are all the aims of the current medical travel work that's being done, and it's being done on 3 fronts. So we're doing some accelerated medical travel improvements. The department is undertaking medical travel modernization, and the sustainability unit is looking at medical travel writ large in terms of big P policy. So we've got all 3 working actively. We're improving at the same time that we're actually designing and rebuilding the system. What I see is it's not fundamentally flawed. It feels like that because when you're on a receiving end and it doesn't go well, nothing goes well. It's such an important and key component of that patient journey. But I got to tell you that for the vast majority of cases, we don't hear the concerns or complaints. We don't see them or witness them. Now, that's not taking away from the fact that there are problems. So there are problems. So Kim, did you want to talk about the subtlety of the policy differences?
Ms. Rhodes, yeah.
Thanks. So the question specifically was around escort eligibility for interpreters. So in general, that is an eligibility criterion. But there are always nuances to certain questions or certain appointment types, et cetera. So I can't give a blanket response on every single medical travel interaction and whether that would be an automatic yes or no. But it definitely is one of the criteria in the policy that allows for an escort. I would also just perhaps add that there are a lot of moving pieces right now as public administrators just speaking to in terms of reviews of medical travel underway. And the complexities of working within this program and all the benefit entitlements, et cetera, like I can't overstate it. There's a lot that the folks that are working in this program every day deal with. If you look at our dashboard with our limited indicators, but one of them is that we move over 23,000 people a year currently. Our staff haven't significantly increased over that time period where we've seen this, 40% rise in medical travel, and in some regions over 100%, like a doubling of the volumes. So it is a program that, struggles to keep up and to maintain service standards. So we're really happy that the work is underway around medical travel modernization, which includes workload analysis, as does the work that the HSSU is undertaking in their review. We're hopeful that the resourcing for this program will improve in the future, including, leadership, because this is a program that, has all that volume of work, like I said, and it spends all the money that you guys are aware of, but it doesn't even have a funded director position. So it is a program that, can definitely use the attention that is currently being given. And our hope is that in the future that we'll be able to improve the experience of residents having to access it.
Yeah, thank you for that. I would be happy if the healthcare system was like a Toyota. I love Toyota, because they don't break easily. And Ford Focus and, Corvette, it's not made for the North, some of those things. So if it was like Toyota in the Northwest Territories, especially in small communities, I think we'll be thriving, So I'm glad you mentioned that. I don't know why he used Ford Focus and Cadillac as analyzing the healthcare system that way, but that's okay though. My colleagues here is a fan of Toyota too as well. But I mean, it's just that it's describing it. We know the model. So, but I think now that getting away from that. So you described in your report that improving technology, training, and quality, quality and the safety. It's all described in your report. So to make that improvements, medical radiologist machine. There's a 2-year wait list. For some of my constituents. They're saying that they have to wait 2 years. They've been, for a CAT scan. So I don't see, if you were making an improvement, we're close. And then I know that we have lots of aging infrastructure, and our healthcare center is one of them too, which needs to be upgraded and it needs to be improved. The medical radiology machine, it's a good career opportunity for our young people. It is a really good, because I've been hearing quite a bit of our young people talking about that, and they research that and where they can go to school for that, SATE, where it's being offered. So they look that up. So why medical radiology machine is not part of the plan to make some improvement, to one of the largest indigenous community like Det'anchogh. And even with that, lately, a lot of our people are requiring kidney dialysis services. Even piloting that would be help improve the system. So so that's why I'm asking, if we're making some improvements, why, how come some of these technology is not being, implemented into small communities? Thank you. So Mr. Doody?
Thank you, Madam Chair, very much for the question. So I can tell you that MRI and CT expansion into the territory is something that we're actually actively reviewing and looking at. It's also tied in some to the D&D work and Health Canada work in ISK with the territory and CERNAC on the Northern Health Assessment. So there's lots of those things actually ongoing in the background, and discussion about some of the D&D investment and the money that's going to come from the federal government and how to improve those services. Their report is supposed to be completed by the end of this month, and so we'll have a better insight on some of that as well. But I can assure you that they are actually active discussions. And just 2 weeks ago, myself, I had met with the chair of Aurora College, or the president of Aurora College, to actually start initiating some of those discussions about how we can start offering programming through some of our partner entities to prepare for when that equipment arrives.
Okay, thank you. So I want to say thank you to the public administrator and your team for appearing before us, updating us on your work plan. So this concludes our public briefing.
Thank you so much.